first question was from a physician that said that they have a physician actually that has concerns regarding fibrinogen levels. How would I use that as a guide? I actually also use fibrinogen levels. There are a lot of places that don't. You'll hear at different workshops discussions on this. I do use them. Early on in training, we were taught that if the fibrinogen levels precipitously drop, there's a higher concern that you may set yourself up for a bleed, a spontaneous bleed, and I've kept that in mind. So we usually get a baseline fibrinogen, and even though that it may be low to begin with, I have on the EMR standard order sheet that once it drops below 125 to notify me immediately, and all DIC screens are drawn stat every 6 hours so that we can keep an eye on that fibrinogen level. And again, if it drops below 125, it should give me enough time to react to it. If it's a slow drop, I may drop the dose in half, or I may turn it off and restart it in several hours after checking fibrinogen levels and making sure they come up. But I do use it, and again, it's really more for, I guess, a prophylactic identification of somebody who may be dropping significantly and trying to avoid a spontaneous bleed. The second question is from a physician from Taiwan, actually, who asks that he gives an example of a case that was performed on acute on chronic DVT of 22 years of the left femoral vein. And basically the technique was that he says after 1 week, I'm not sure, that he would have an EKOS in for 1 week, but that the femoral vein still looked bad. Used balloon angioplasty up to 7 millimeters under IVUS guidance. Final flow was acceptable, but several points look at least 80% stenotic in the femoral vein in spite of prolonged repeat ballooning. Can he stent the femoral vein? I personally would not stent the femoral vein. I do not go below the lesser trochanter. I do not want to jail the profunda inflow. But I will tell you that 7 millimeters to me is way, way undersizing. If you use IVUS in a chronic DVT case, even though you have a lumen and you have flow, that vein is not yet back to its normal size. Remember, it is scarred, so you can stretch that vein out. I don't know the last time I have undersized below 10 millimeters in a femoral vein. It's just not a very common scenario for me. So I will slowly and methodically dilate up to 10, leave it up for prolonged dilatation in this case, but I'd like to see wasting of those residual stenoses that he describes at 80%. I would dilate that balloon until I get effacement of that wasting and keep it up again for prolonged dilatation and try to really stretch out that vessel. When I have seen failures, typically it's because I undersized the balloon. So it's really imperative to try to maximize balloon dilatation to the best that you can. And again, anticoagulation is also key. You really want to make sure you anticoagulate them up front so you don't get rethrombosis. The next question, is it a must to pre-dilate before EKOS? Can EKOS be used up front after crossing wire? I have found that many of the cases that I do, the clot, the chronic veno-occlusive segments are very hard to cross, and unless I create some space, I will not be able to get flow. And I want to start to at least initiate flow through there, and I do believe that we're creating a lot better luminal gain by ballooning. Whether you believe in EKOS or not, you're going to want to dilate, and so why wouldn't you dilate up front? The second reason is because infrequently I'll dilate up to the expected diameters of these segments, and I've got brisk, beautiful flow. And so in a handful of cases, I've not even had to go to EKOS. So why would I go to EKOS if I could and take a risk for bleeding with TPA if I don't have to? So I treat everything to the point where I maximize balloon dilatation before I do the EKOS. And then I usually will do the EKOS infusion overnight, so minimum of 12 hours, typically overnight. So it's usually between 12 and 16 hours in total time. Iliocaval filters, are they routinely required for the procedure? No. I truly do not use filters for any chronic, whether it's acute or chronic DVT. I do not use filters, and I would think the majority of podium speakers, when we talk about this, the vast majority, almost everybody, does not use filters unless it's really indicated for somebody that may have a submassive PE that you don't want to have a risk, for example. But there are certain scenarios, but generally speaking, we do not. Question on anticoagulation, is it required for long-term or for a finite period of intervention? That really is defined by the baseline situation. If someone has a hypercoagulable state that you cannot remove, then it may be for life. I do get hematology consults and input on almost all of these cases and allow them to give their feedback. In somebody who may have had, let's say, a May-Thurner compression, who we've treated, stented after they've had the thrombosis recanalized, if that was really the only cause, I will actually keep most chronic DVT patients that we've removed any potential thrombotic event. I will keep them at minimum 1 year. I convince them to go 2 years, and then after 2 years, I'll go to an antiplatelet, usually aspirin, Plavix sort of therapy for a period of time before we consider getting them off. But typically, most patients, I'll go 2 years that we transition from Lovenox or enoxaparin to one of the oral agents at a month out. Go to the next question. So what does the exercise program entail? That's a great question. I should probably define this more. Exercise to me is working the calf muscle. I've heard, over the years, many of our vascular surgeon colleagues, when we talk about the calf, it's the pump. Really, the calf is the pump of the leg. That's the line that you hear all the time, and I truly believe that. So my exercise program is simply getting them to walk, getting that calf muscle, the gastrocnemius muscle, to squeeze, to move blood. So I ask them to at least walk around the block several times a day to start, and just try to increase that as much as possible. Get on a bike, get on a treadmill. And it's amazing how people will really work hard at doing this, knowing what they came from and where they're potentially going. And many of these patients are feeling better very quickly, so they're happy to be doing stuff. Duration of anticoagulation post-procedure, I think I answered that. It really is based on the reasons for thrombosis, but as long as you've removed them, I will try to go out 2 years in total before I switch them to antiplatelet-only therapy. And again, we're talking about the chronic population. What type of stents used for IVC and iliac? So, great question. The appropriate answer is that you want to stent to the size of the vessel. And since most patients are 22 to 24 millimeters in the IVC, I will use commonly 24 millimeter wall stents, and occasionally I'll use Palmol stents that I'll put on a large balloon, dilate, and then post-dilate up to 22 or 24. And then because we have really up to this point not had venous stents, 16 millimeter venous stents on the market, I use 14 millimeter self-expanding stents. There are obviously a variety of stents that are out there on the market. I just happen to use the Protégé stent. We've had very good results with that. And I'll use 14 to 12s down through that common femoral area, again, to the lesser trochanter if needed. And I'll kiss them well into the IVC to get a wide margin of overlap. And the patency rates that we've seen for iliocaval thrombosis have been really, really good by using that combination. Next question. I guess the difference between 0.5 or 1 milligram per hour, that's really based on the extent of the clot and the size of the patient. I usually go a milligram per hour in larger and in more extensive clot that may be iliofemoral, popliteal, the entire extremity. If it happens to be a more focal fem-pop, I probably will use the 0.5. But it's also dependent on how much acute clot I see form during the case, which is why I initially started using TPA. The TPA is not really for the chronic collagen-laden occlusive disease. It's more for the acute thrombosis that still can occur despite the fact that they're on anticoagulation. And I oftentimes will see filling defects after we've dilated that look like acute thrombus. And I don't certainly want them to thrombose off while I have a catheter in the tibial vein when I get access. So it's really prophylactic for more clot and active for the acute clot that may be forming. I've been asked to elaborate on the stent preference and average time for recanalization. When I schedule these patients, I don't want to be rushed. I want to do justice by the patient, so I will either schedule the full morning or the full afternoon. In the beginning, it will take a good 3 hours to work through a chronic occlusion. But I will tell you that over time it gets quicker. On average now, it's probably an hour to 2 hours to do a case, and that could include the IVC. So just give yourself enough time so that you're not rushing to get through. If I fail the first day, I'll oftentimes tell them I'm going to leave a sheath in and I'll bring them back a second day. It is incredibly rare that, number one, you fail the first day, but it's even more rare that you're not able to cross and treat these patients and get them open, especially on the second day. And you know the anatomy, you know what you've done, it's fresh in your mind. So I think the second day has been very successful in gaining the patency that you want that you failed to do on the first day. And I think I really talked about the stents that I use. Again, you want to use large stents in the IVC, 22, 24. I try to get up to 24, and the second one is for the iliacs. I use the protégés, but again, most people, everybody has their preference on self-expanding stents. Question about where do the patients go if not to the ICU? We send them to the vascular floor bed. It's a step-down bed. The nurses have been wholeheartedly enthusiastic about taking these patients. They love it. My previous hospital, we did that for about 7-8 years before I left. At the current hospital, we also do it. There was a lot of resistance in the beginning. They've engaged this program. They love taking care of these patients. These patients are typically very thankful patients. They're easy for them to take care of. So we go to a vascular floor bed. And I was very happy to see in the results that the majority of patients across the country actually went not to the non-ICU bed. So I think we're saving a tremendous amount of money to the system by not using the ICU unnecessarily. In the posterior tibial vein access is not favorable, do I use Patty Thorpe's technique of flow-directed pedal infusion of TPA? So, again, I have rarely seen a tibial vein, either anterior or posterior tibial, be completely occluded all the way down to the ankle. Usually, even though there may be occluded up above, patency remains down below. So it's a very unusual situation. Now, again, you could argue that would you infuse TPA only in a chronic veno-occlusive segment? I think that if the patient is a good candidate, it's worthwhile because I do believe that there's probably some softening that goes up and it may improve your overall outcomes in the end. Patty is a fantastically skilled physician. And, this is not the only one. My technique here and what we've done is not the only technique. The real purpose of doing this was we need to get the information out globally that chronic DVT patients can undergo endovascular therapies and improve their situation. what size do I dilate the common femoral, popliteal, and tibial veins? So I'll initially, day one, dilate the tibials to 3, popliteal up to 6 or 7, and the common femoral up to 10. I will then bring them back the second day. If flow hasn't been really restored, but there's increased luminal gain, something's in there occluding the flow. So what I'll do at that point is redilate to those numbers. If I still don't have flow, I'll slowly dilate up to the next level, tibial to 4, popliteal to a 7 or 8, and a femoral 10, 11, 12, and just gently and slowly progress until you get the result that you need. But typically it's because we just haven't gotten stretching the vessel well enough. What is your main go-to wire? In crossing initially, it is a stiff, straight glide wire 035 with the angled nav across. That way I can direct it. It gives me really a lot of good pushability, but that's what I'll use. And again, the vast majority of the cases, I'll be able to cross with that system. And occasionally when I fail, I'll go to the Cook Triforce system, and that usually does not fail in getting across. If there's a contraindication for Lovenox at discharge, what alternatives would the patient receive, or do they progress to an oral agent? This is a great question. I'm not sure if I've really come across a situation where I've treated somebody who has a contraindication to Lovenox. But the next best thing is to try to give them an oral agent that's going to be quick, effective, and so I would go with one of the newer oral anticoagulants, simply because warfarin is going to be difficult to get to a level right away. So I would use one of the oral agents, BID dosing. I would also very strongly consider putting them on an antiplatelet, aspirin, or Plavix in the short term. I think that I can tell you that when the oral agents came out, I was very excited, and I went straight to them and negated giving Lovenox up front. We went right to the oral anticoagulants. We found an incredibly high rethrombosis rate within 30 days. And the belief is, having discussed this, and I have multiple friends out there that have said the same thing, and we've all gone back to Lovenox. There is a property within Lovenox that we believe is probably the difference, and that is an anti-inflammatory agent. And I think the patency rates early on, while we've inflamed these vessels from working on them, is why we get the better results with Lovenox. But I think you just have to do the best with your alternatives, and I would absolutely get your hematologist on board with something of this nature if there's really a true contraindication to Lovenox, to try to get the best you can. What do you believe is the mechanism of action on TPA, collagen-rich chronic clot scar? I think I answered that already. The TPA really is for the acute and prophylactically to prevent while we're in there. I do think that the EKOS, and some colleagues are believing that TPA may have an effect in loosening some of these strands in the collagen-rich scarred vein. I'm not sure. We haven't proven that scientifically, but I think the combination does definitely improve it. I will give you anecdotal experience. Early on, my colleagues and I at the hospital thought if EKOS was really doing anything, so we looked at, I don't know if it was a dozen or 20 or so patients in each arm of catheter-directed lytic therapy versus EKOS, and although the first 30 days or so were very similar, they started to digress, and the patency at EKOS at 3 months and 6 months was better, and that's why we ended up going to that mechanism or I should say that protocol for treatment. So again, it's worked for us, and it's clearly worked for the centers across the country that were in this trial. I've had numerous physicians say they never thought they'd believe it, but they, having done the trial, they've clearly seen a benefit to the patients. What is your duration of insufflation for PTA post-EKOS? Again, prolonged dilatation, 2 to 3 minutes. I think we're all, of the belief that we think something's been up for 3 or 5 minutes and it's only been 30 seconds. You really have to be patient. Brooke Spencer's talked about this for years, and I I believe that prolonged dilatation and really stretching that vein is how we get the results. One interesting anecdote I will tell you that I've seen over and over is that a scarred vein, when you follow them up with Doppler studies, be careful of what the radiologist will read, that there's chronic thrombosis, and you have to look at these images. You want to see color filling wall to wall. The wall will still be thick. It will be non-compressible in the beginning. But after somewhere between 6 and 12 months, that wall starts to coapt. And when you follow these patients out 18 and 24 months, and I follow my patients out 5 years, you will see what was very rigid, non-compressible vein walls compressed like a normal, absolutely normal vein. So it's an amazing phenomenon that we get remodeling, I think, in the venous system just as well as the arterial system. And the question was, do I occasionally go to 12 millimeters for the upper femoral vein? Absolutely, for the reasons I've described already, that I was getting poor flow, wasn't able to keep the vessel open, and so I really want to stretch it and dilate it up more. Is there a role for outpatient management of these cases? That's a great question, but I can tell you that unless you were able to get brisk flow with balloon alone, in the U.S., you're not going to get paid for lytic therapy. They have to be an inpatient, at least currently. You have to be an inpatient in the hospital for reimbursement. So I think, the question is whether or not in the acute setting you could get away with a one-and-done session with something pharmacomechanical, and I think you could definitely do that. But I think the majority of these cases, since they really don't open up with prolonged balloon dilatation the first day, I would just tend to, at this point, do them in the hospital. That may change over time. How about patients who are younger, who have extensive DVT, or at high risk of PTS, who do not yet exhibit the most severe of symptoms? Would this approach be applicable? Yes, it is. I've done that on patients, absolutely, who are young. And the reason is for just what you said. High risk is clearly there. Most of these patients, I will tell you, in the younger population, have been people who did not know they had either an atretic or a previously thrombosed IVC in addition. For some reason, they present with swelling of the leg, not diagnosed with DVT, but then may get an acute DVT, or just have persistent swelling. We get central imaging, and we find that they have an IVC occlusion, whether it's a congenital or something, again, that happened either in utero or postpartum is uncertain, but you can and will establish better flow. And I'll tell you, what you will see are patients who come back and follow up saying they never realized how affected they were, and that their exercise tolerance is immensely improved, and that they're doing things they couldn't do ever since they were a child. So I would absolutely go after this population for those reasons. Do you feel that endophlebectomy of the common femoral profunda has a role in treatment of post-thrombotic syndrome? I think it absolutely does have a role, but and I've been involved with the debates at multiple meetings with the vascular surgeons about this. My belief is, first of all, endophlebectomy is not easy. It's got to be a very skilled person who can do it and do it well. And oftentimes they'll put an AV fistula in to keep it open, but you can get lymphoceles. They're not of the uncomplicated type of procedure. So if I can get direct inline flow, our results, I should say, will certainly, I think, outdo that of surgical. And I think it's best to get inflow directly from the femoral vein than just doing an endophlebectomy. There may be a role in combination, but I would certainly go this route before I would succumb a patient to a surgical procedure that may or may not do them any good. What about extravasation after PTA? That's a great question. Wires will go out. Sometimes you'll balloon dilate, and you may get a little bit of extravasation, although I will say it's more to see with the wire going out of a vessel than it is with angioplasty itself. But if that's the case, I will go to a smaller size balloon. I will do prolonged dilatation, and do follow-up venography. Oftentimes, there will be no further extravasation by the time you get to the EKOS portion of it. And if there was extravasation and I really am worried about it, I'll put actually a wrap, a pressure wrap, ACE wrap around the area to try to minimize any sort of further extravasation. But I don't shy away from proceeding with the procedure as intended and going forward with EKOS, and I've not gotten in any trouble. And most of my colleagues who have done this agree that they've been able to do the same thing. There is a question regarding the timing of treatment in a known acute, subacute on chronic disease. Found that the subacute DVT is particularly difficult to cross, especially if subacute on chronic. If the DVT is longer than 14 days but yet not 6 months to a year, is it your practice to wait 3 months, 6 months, 12 months? I've not actually found that to be the case. I will treat with a rapid lysis pharmacomechanical technique out 4 weeks. I've had no problems being able to successfully treat those patients and get great results just as if it was 2 days, let alone 1 month. So that will not stop me from going out. I agree that there is a part of time where you're into the chronic, the early chronic, where things are maybe more rubbery than they are of that collagen, hard, fibrotic sort of tissue. And I think that that's probably more of the difficult time to treat. But in all honesty, the time to treat is more based on the patient's symptoms. And if people are really suffering, I won't wait. I'll get in there, whether it's 3 months, 6 months, or 12 months. I'll go in and do everything I can to recanalize them. And thankfully, the results have been the same. I don't find that a subacute crossing is any more difficult than a chronic. I think the chronics are clearly worse. So I would go ahead and proceed and just give yourself the time to make sure that you're not rushing and do the things that we've talked about tonight. And I think you'll find yourself that it will go well. Question for low fibrinogen, again in Taiwan. They check the fibrinogen every 3 hours to monitor, adjust the thrombolytic dose. If low fibrinogen is noted, they give cryoprecipitate to elevate it, to keep the EKOS going, also titrate lytic dose. Yeah, I don't go to cryoprecipitate at this point to elevate it. I just monitor it and titrate the lytic dose. So I've not gone to that. The only time I would give cryo if somebody was critically low and at risk for bleeding, and critically low I mean below 50. So I just would not give blood product until I know that it's absolutely needed. I would just adjust the dose. I would turn it off. It can rise quite quickly, actually. So, second question here. After EKOS POBA, do you really need to use enoxaparin for 1 month and then shift to a NOAC? I'm just giving you my experience and the experience that we saw in the trial, which is why we really pushed it, is that, again, there is, I believe, the anti-inflammatory property of enoxaparin that benefits patients that the NOACs, DOACs, whatever you want to call them, don't have. And I know that it's more comfortable, but I'll tell you, if you explain to your patient, I apologize up front, you're going to have to give yourself a needle twice a day, but the outcomes are going to be beneficial, and you're going to do much better if we do it. They will do it. They will do it, and they'll continue it for as long as you tell them, knowing that they've suffered from post-thrombotic syndrome for so long. Do you use drug-coated balloons or drug-eluting stents? And I will tell you, no on the drug-eluting stents. They're just not big enough. And I don't, again, believe in stenting below the inguinal ligament. So, but drug-coated balloons, interestingly, I've used them probably 4 or 5 times since they've been available. And most of them have been at the popliteal level. For somebody who has recurrently stenosed that area, hasn't thrombosed, but clearly on the Doppler study and follow-up and on evaluation, they're, initially for the first month or so, their symptoms got tremendously better. Their Villalta score, VCSS score, quality of life were all improved, and then they start getting worse on follow-up. They've maintained everything else that we've asked them to, and if there's been, on venography, when I go back in to look at the reason why, typically I will see that there is a narrowing down, a scarring down, and I've used the balloon, and I will tell you that there has been some benefit to that. I don't have long-term data on it, so I can't tell you at 12 months or 18 months that they've maintained beautiful patency, but certainly early on, up to 12 months, I can tell you that there was benefit to it. So it may be something to evaluate going forward in the future, certainly. Any stent fractures when stenting the common femoral vein? I have not seen them. Interestingly, I know in the arterial system we talk about it, but I don't know if it's the more robust 12-millimeter stents that are less fracture resistant. Plus, the drug elution stents, we also had that problem, and we're not using them here. So, but we've not seen problems with fracturing with the commercially available stents that we've been using. Again, a question from our friends in Taiwan. After treating chronic DVT and stenting of the iliac vein, what is the medication afterwards? Aspirin and Plavix for long term, still with enoxaparin 1 month. Then, so the question, I guess, if it's chronic DVT, we're not talking about a non-thrombotic May Thurner, which I would treat with you could argue aspirin and Plavix, for 3 to 6 months versus any anticoagulant for several months, and then transitioning to aspirin and Plavix. In this population with chronic DVT, again, I would absolutely go with the enoxaparin 1 month, a DOAC or a NOAC for the appropriate period of time out at least 1 year, if not 2, because, again, we treated chronic DVT. I want that vessel to remodel. I want to see it looking good before I start to consider stopping them. When I see coaptation and normal flow phenomenon within on a Doppler study, that's when I really start to look at changing the anticoagulant to an antiplatelet. Do you still give TPA day 1 if you can't cross? No, I don't typically do that because I want to get to the other side. And I'll tell the patients, I have no idea whether we're going to be successful to start, but what I can tell you is if I can cross the occlusion, get to the other side, there's about a 90 to 95% chance we're going to improve their quality of life, and that has been true. So I don't give TPA if I can't cross day 1. I bring them back, and again, you really I haven't had a failure trying it on day 2. Do you still give TPA for catheter extravasation? Again, I hope I answered that question earlier, but prolonged balloon dilatation, stop the extravasation, which typically occurs. Again, these are chronic scarred veins. They seal up pretty well. Just a lower pressure balloon, a lower size balloon, prolonged dilatation. Let it sit for 5 minutes. Repeat the venography. I'd be amazed if you see extravasation at that point in time. And then once you cross and you're able to get from one end to the other, I would still then dilate up to the expected size, put the EKOS in, and treat them as if you never saw the extravasation to begin with the potential of putting a wrap around there to help prevent any further extravasation during the night. I think that is it. We've run out of time. So, again, I want to thank you all very much for tuning in tonight. If you have questions, reach out to your rep, and I'll be happy to try to get back in touch with you with any questions. All right? Thank you again for the evening. Appreciate it.